us for an exploration really this evening about a very common GYN concern and also what the treatment options are for you. We are joined by a couple of great uterine fibroid specialists. My name is Kristen Smith. I am the outreach coordinator for Oakdale ObGyn. I am joined by Andrew Meyer, who is our technical consultant, and then by our two physicians. I want to just go over a couple of housekeeping things before we get going. And the first one probably is that if you need to bug out early or whatever, this webinar will be available on our website starting tomorrow. You are also welcome to share it with friends and family. We invite you to, and also to rewatch it. There's going to be a lot of information that's presented this evening, and it's really important that you take in the information, but then two, maybe you make an action plan. And sometimes it's going to take a little bit of time to get exposed to the content. I'm really psyched because Oakdale ObGyn is really unique in the state of Minnesota. We have two physicians who are fellowship trained in minimally invasive surgeries. That means for people that are out there that they bring advanced skills and knowledge in a wide range of types of things that you're going to hear about tonight. And I really encourage you to ask questions. We will be taking questions primarily at the end, but if there are questions that arise in a certain content area, certainly put your questions either in the chat box or in the Q&A session, and we'll tag team on those. And without further ado, I'd like to introduce Dr. Matthew Palmer. He is our medical director of the Center for Urinary and Pelvic Health, which also includes a uterine fibroid specialty center. And then he is also joined by Dr. Jenny Zhang. And Jenny is going to be kicking off the content, and then we'll be joined by Dr. Palmer. So I'll turn it over to you.
Hey, thank you, Kristen. Hi, everyone. Good evening. Thank you all for joining us tonight. It's great that you guys could all make it. As Kristen mentioned, I'm Dr. Jenny Zhang, and my partner here is with me tonight, Dr. Matt Palmer. So as Kristen also mentioned, we're both fellowship trained in minimally invasive gynecologic surgery. And what that means is we've treated many, many women with fibroids, and we can offer the full scope of treatment and care if you have fibroids or have problems related to fibroids. The program that Dr. Palmer and I have put together will share with you information on fibroids, what they are, what symptoms they may have, and if you have fibroids, what you can do about them. One of our main goals for this session is to share with you the information and make sure that we answer all the questions that you want to know. So after our presentation, we've made sure to save lots of time for a question and answer because we do want to hear from you. So let's get started. Women play a critical role in maintaining the health of our families. However, when it comes to our own well-being, many women may tough it out or battle silently with health concerns that we don't want to discuss or don't feel that we have time to discuss. Whether it's recovery after having a baby, heavy and painful periods, urinary incontinence, women deal with conditions that can be difficult. Tonight, we're going to discuss in depth one of those conditions, fibroids. So what are fibroids? Well, let me first start off by saying that the organ in which fibroids are grown is called the uterus. The uterus is a muscle. It can grow and expand like in pregnancy, and it can also squeeze and contract like with labor or menstrual cramps. And when one of those muscle fibers overgrows and turns into a ball of muscle within the wall of the uterus, that ball of muscle is called a fibroid tumor. But when you hear tumor, I don't want you to worry because most of the time fibroids are benign or not cancer. Fibroids are very common. About 25% of all reproductive age women will be diagnosed with a fibroid during their lifetime. 60% of African American females and 45% of Caucasian females. So who gets fibroids? Fibroids are a disease of all women, but African American women have a higher rate of fibroids. 60% of African-American women have been diagnosed with at least one fibroid by age 35. And then 1 in 4 African-American women will be diagnosed with a fibroid between age 21 and 30 years old, which means that African-American women are more likely to get fibroids by a younger age. Obesity is another risk factor for uterine fibroids. And then there's been a link with certain diets that are heavier in red meat and the growth of fibroids. And then family history. People that have family members with history of fibroids are more likely to have one, but if you don't have a family member with fibroids, you could possibly still have one as well. So fibroids are characterized by where in the uterus they grow. And the location is really important because where the uterus has the fibroid can impact both the symptoms that it presents as well as the treatment options available. So this picture that you see here is what we're going to use in the next couple of slides to show you exactly where the fibroids may be, what the symptoms are for those locations. So first, let's start off with submucosal fibroids. So these grow inside the uterus, just under the lining of the uterus. And so what they can do is they can disturb how smooth the lining of the uterus is and therefore cause very heavy periods because that lining is what comes out as your period each month. And so if something grows and sticks into the inside of the uterus, you can have very long periods, more than 7 days, 7 to 10 days. You can have very heavy flow and they can be painful as well. Also, if you have a fibroid in this location, the submucosal location, it can prevent you from getting pregnant or possibly lead to miscarriages. Next, we have the intramural type of fibroid, which grows within the muscular wall of the uterus. Now, this type of fibroid, if it's really small, can cause no problems at all. You may never even know that you have one, and that's fine. But if it starts growing into the inside lining of the uterus, it can lead to the same type of heavy bleeding, long periods that those submucosal types did. Or if it's growing from within the wall of the uterus and starts growing out and sticking out, it can cause pelvic pressure, pressure symptoms like constipation where the fibroid rests on your bowels, or it can cause urinary frequency from pushing on the bladder, and even symptoms like painful sex. And then for pregnancy, the symptoms of an intramural fibroid are again variable. They can either range from no problems with pregnancy whatsoever to, if they're big enough, they can cause the baby during pregnancy to stay in a breech position and not be able to go head down, or they can cause labor to be slow or possibly prevent vaginal birth, and they can potentially cause increased bleeding at the time of birth. And then again, as I mentioned before, sometimes they can cause no symptoms at all. And then lastly, we have the subserosal type of fibroid or pedunculated. And these are ones that grow within the wall of the uterus, just under the outer lining. And so these will often grow and extend outwards from the uterus. Because they don't affect the inside lining of the uterus, some women with these fibroids never experience any problems with their menstrual period. Bleeding is fine, no problems there. But they may have symptoms over time of back pain, constipation, even sometimes the abdomen can protrude due to this fibroid being so big. And then similar issues related to urinary frequency, pressing on the bladder, and pregnancy issues as well. So now Dr. Palmer is going to go into how one goes about figuring out if you have a fibroid or not.
All right, thanks, Dr. Zhang. So I think, just the understanding of what a fibroid is, I think is helpful in kind of thinking about and informing how we might think about treatment options. We'll get into that in a second. But what I want to address is, kind of the idea of the diagnosis of fibroids. Like Dr. Zhang said, many people have them and they don't know they have them. They may be found incidentally, meaning that like if you have a CT scan for some other condition, like you're in an accident or something, you're in the ER or something, and a scan is done, or maybe even a routine OB ultrasound or something like that, a fibroid can be picked up. And, then kind of what needs to happen from that point is kind of an understanding of what does that mean, and so when we see a fibroid on some type of imaging, we want to be able to evaluate it in the best way that's going to help us understand how we move forward. So sometimes the most likely diagnostic modality is an ultrasound, a pelvic ultrasound, which will help us to determine, and you can see that sort of that background image there. It's fairly grayscale. There's some shapes that you can see, but it's still kind of it definitely takes a trained professional eye to be able to really delineate where it is and the size and the measurements and everything. And so sometimes we'll think about getting some further imaging, something like a pelvic and abdominal MRI, which will also help us really determine the specific location in relationship to the muscle layers, the size, and also it's really instrumental in when we think about a procedure to remove fibroids, kind of a map of the uterus to help us understand, how we can approach that, whether it be, through a certain type of incision, or how many incisions one would need, or the expectation for how many fibroids one's going to be able to remove. That MRI will give us a really more specific view of the problem. And so those are the two main modalities. Sometimes we'll also use a scope called a hysteroscopy, where we come in with the camera from the cervix from below, and that's where we're able to visualize those submucosal fibroids, those ones that are in the lining, and that we can be able to see, the size, the contour, how it's affecting the uterine cavity, to be able to understand if that type of fibroid, number one, is problematic for something like pregnancy concerns, but then also it's possible that a fibroid of that nature could be dealt with without an incision on the abdomen, but working through the camera through specialized tools to be able to remove the fibroid hysteroscopically, through that scope. So we'll kind of use a variety of those modalities in that, depending on a patient's symptoms, we'll take a detailed history, we'll take understand maybe historically what a person's menstrual periods have been like, how maybe they've changed over the years, things like pain, and Dr. Zhang mentioned, some bladder problems people might have, bowel problems, and all those things are related to kind of pinpointing the significance of fibroids for a person. Okay, so we'll go on to the next slide. Treatment is really something that is, it's not a one size fits all issue. And so people might think, I have fibroids, we're just gonna do XYZ, but really, the reason that I think it's important for you to be having a consultation for your problem with somebody that can offer you a variety of options is because there are a variety of options, and sometimes nothing needs to be done. And sometimes, we can design a procedure or a surgery that will help take care of the fibroid in a way that, could potentially remove only the fibroids and preserve the uterus. Or sometimes, pregnancy considerations are very important, whether one wants to maintain the ability to, have a pregnancy, or whether it's affecting their pregnancies. And so, we want to, number one, understand, do we need to do anything? Is this a situation where we could observe, we could see if it's going to get larger? Is it actually having any impact on your current situation, or is it not? Sometimes these fibroids are amenable to a medical treatment option that's non-surgical or non-procedural. And, I'll kind of talk about that as we get a little further on here, but that can, essentially be kind of potentially a stabilizing procedure where the symptoms can be alleviated. Generally, those medical medical therapies are not going to remove the fibroids, but they're likely going to cause the symptoms to abate, while you're undergoing that treatment. And then, there's a variety of surgical options. And so many people, I think it's important to point out that, who you see and their experience and their skill level and kind of their knowledge of how to manage fibroids is important, because I think many people are offered, that come to me anyway, are told they have to have a certain type of procedure. Maybe they have to have an open abdominal surgery to remove fibroids. And then we can talk about that and say, hey, maybe there's a better way. Maybe we can design a procedure that would allow you to have a same-day surgery, or, a much shorter recovery that would be not so, difficult to get through. And so those are kind of some of the basic ideas of treatment options. I'm going to talk a little bit now about different types of medical therapies. So, kind of the basic idea behind fibroids is that these are hormone responsive type tissues, meaning that they generally follow a woman's menstrual years, and they'll grow in the presence of estrogen generally. And like Dr. Zhang pointed out, there's things that can sort of make them grow faster or be more prevalent. And so, one of the things that we sometimes do is we try to modulate or stabilize a person's estrogen with a birth control pill, essentially. Now, we're not, necessarily preventing pregnancy in this case, but we're trying to design a therapy that's going to keep your hormones kind of following a pattern, a steady pattern, whereby you can eliminate some of the kind of the high rise and fall of estrogen in a person that will potentially stop or slow the growth of the fibroid. What progesterone does is it kind of stabilizes the endometrial lining, and so sometimes some people will do better on a combination pill. Sometimes people will do better on a progesterone only pill, depending on the specifics of how their fibroids and their symptoms are responding. And so we want to kind of be thoughtful about that when we're thinking about prescribing. And most people that are on a medical therapy like hormones are on it because they're maybe buying some time. It's not a good time to have surgery. They're thinking about maybe their symptoms aren't severe enough that they need to be removed at that time. They're kind of using a conservative option, let's say, to try to deal with their symptoms right then and there, rather than a more aggressive option. Now, one of the things that we've been excited about in the last couple of years is a new type of medication that's called a GnRH antagonist. And you can see the box of the medication there behind. Basically, what this medication does is it lowers your body-wide estrogen levels, okay? And it basically kind of turns down the estrogen, kind of like turning down the burner, the flame on a burner, okay? So it's kind of a modulating medication where the estrogen is lowered. It's not completely wiped out to where you're in a menopausal state. And the other good thing about this is that this medication also has a little bit of add back therapy, meaning there's a little bit of hormone in it as well, with the intent of this medication being different than birth control, and that we're actually lowering the estrogen, which data suggests from the trials and our own personal experience with treating patients with this, that it really does a great job of reducing bleeding drastically. And that's kind of the main benefit to this type of medication, is that now it may or may not shrink your fibroids. It certainly will not remove your fibroids, but it will, for many people that are suffering from very heavy menstrual bleeding related to fibroids, it will definitely slow or even stop, in many cases, the heavy menstrual bleeding related to fibroids. All right, you can go to the next slide. So one of the other things that's a potential idea for treatment of fibroids is a method called uterine artery embolization. This is a procedure that's done by radiology, by a radiologist, and it's actually a procedure that goes and targets the blood supply to the uterus itself. And what it does is it can be some small beads can be placed inside the vasculature that leads to the uterus through the femoral artery. And what that can do is actually slow the blood flow, not enough to cause harm to the uterus, but enough that, because these fibroids are very vascular, they're very rich in blood supply, and the uterus can be very hypervascularized when someone's growing uterine fibroids. And so one of the ways that we can treat that is by slowing and reducing the blood supply to the uterus enough that you can get some shrinkage of the fibroids and some alleviation of those symptoms. Now, my personal experience is that this can have, I would say, variable results. Some people do perceive benefit from this, but it's a little bit of a guess as to whether or not it's going to work for people. It's not quite as cut and dry as some of the other modalities that we have, really excellent statistics on and data on efficacy. This is a little bit more like something to try as an option, but it may or may not be effective for each individual person. So then we'll go on to talking about what I mentioned before, which is hysteroscopic. Okay, so again, I'll just to recap, hysteroscopy is where you go in, like you can see on the left-sided picture there, with a camera in through the vagina and through the cervix, visualize the inside of the uterus, and then place through a camera port, through a little special channel in the camera, a tool that can actually remove the fibroid. I tell people it's kind of like a Pac-Man kind of thing. Okay, so the fibroid, this little blade kind of chops up the fibroid, and there's a little vacuum component to the device where the tissue is suctioned into the vacuum and into a trap, so we can get that tissue and send it for pathology evaluation. But it's a way to kind of shave down the fibroid to remove it that way. And you know, the ability to do this sort of depends on the size and the location of the fibroid. And sometimes we'll use this modality in conjunction with another approach from the abdominal side if a fibroid is specifically, you know, really deeply embedded in the mucosal layer, and it's the best way to get it is from below. And so what's really beneficial if your fibroid type is amenable to this is that this is a very straightforward surgery to recover from without incisions. You know, it's a same day surgery with a very, you know, very quick return to work with minimal pain and side effects from that. So it's a nice option if a fibroid is set up in a way that can be accessed in this way. Okay, and so we'll often use a tool called MyoSure, which is one type of tool that is this kind of mechanical kind of chopping device that will remove the fibroid that way through the cervix. Okay, and then I'm gonna cover one more slide before we take a little pause, because I know we're throwing a lot of info at you here, and then we'll take a few questions if there are any. Okay, so go to the next slide. And this one, I think, are you going to take this one, Dr. Zhang?
Yeah, I was going to talk about this
Okay.
one.
Do you want to pause for questions if there are any then?
Sure. Let's see.
Anybody have anything that stands out right now, or should we keep going?
I think you can keep going. We don't have any
Okay.
questions at this point.
Sounds good.
All righty. So I'll talk on this, but Dr. Palmer, feel free to chime in if you think I've missed anything. So what Dr. Palmer was talking about before was the hysteroscopic approach if you really have that type of fibroid that is inside the lining of the uterus. And some people have multiple fibroids in various spots of the uterus. So if you have ones that are embedded in the muscle wall of the uterus or sticking out from the uterus, you may then be discussing or thinking about surgery in the abdomen. So surgical options for women that have these bigger type of fibroids really depends on whether you want to keep your uterus or not, and that can be a very personal decision. So one type of surgery is called a myomectomy, and that is where we remove just the fibroid, peel it out from the uterus, and then sew the uterus back up, thus preserving for you the uterus. And reasons for wanting to potentially keep your uterus may be wanting future kids, not wanting to have your uterus taken out, you know, you just kind of want to keep your uterus and not going through any of the risks of hysterectomy. And then reasons for removing the uterus, which is a hysterectomy, so that means taking out the uterus and the fibroids all together as one, are that hysterectomy is really a cure for fibroids. Without a uterus, the fibroids won't grow back and you won't have any more periods. So that may be why some people choose to go ahead with a hysterectomy. At Oakdale, we really strive to provide the best quality of care for our patients, and that means offering the minimally invasive surgery technique whenever possible. And in my mind, and I think Dr. Palmer will agree, our default approach is to use the small incisions and do the surgery that way, which allows less pain with recovery or shorter recovery and not having to stay overnight in the hospital. So really, a patient has to have something that disqualifies her from getting that type of surgery in order not to get it. And so here are the diagrams. You can see the difference in that the either laparoscopic or robotic assisted laparoscopic approach has these small incisions, and we're able to do a lot of our surgeries through those small keyhole incisions, versus the more traditional conventional approach, which is a big abdominal incision that does require a longer recovery and a couple of nights in the hospital. So how we do these surgeries is for a myomectomy. Well, to start off, laparoscopic means we make small incisions, and then with a high definition camera, we're really able to see the anatomy up close and all the fibroids. And then for a myomectomy, we make a cut on the uterus, peel out the fibroids, and then sew the section back up. And then for a hysterectomy, we disconnect all the attachments and blood vessels of the uterus and then take it out with the fibroids still inside. And then because we have our advanced training in surgery, we have a lot of tricks to get out large specimens, large things from these very small holes. So again, hysterectomy versus myomectomy, or taking out just the fibroids and keeping the uterus, is a tough decision. For a lot of people, a hysterectomy is a big deal, which makes sense. You're getting a whole organ taken out. And it's hard to decide what to do. You know, you may not want to necessarily use your uterus to have more children, but you don't really want to undergo a hysterectomy either. And we get it, it's hard. As your doctor, it's our job to help guide you through this difficult decision-making process. And what's more, one of the options coming up is something that helps bridge the gap, fill the need for just picking between these two surgical options for fibroids or bigger fibroids. So a procedure that's coming soon to Maple Grove Hospital is called Exessa. And in this procedure, in this surgery, it's a laparoscopic approach. And what we do is we make small incisions, again, for that high definition camera. And this time we also use a laparoscopic ultrasound that will in real time map out where your fibroids are exactly. And then the Exessa device is something that directs heat to the specific fibroids. And during that heat process, the fibroids can shrink and continue to shrink over time. And so that turns this hard baseball-like tumor in your uterus to the consistency of a soft marshmallow, and therefore lessen the impact that this fibroid has on your uterus. And the benefit of this procedure would be that you don't have as long of recovery as, let's say, a hysterectomy or even a myomectomy, and you still get the benefit of having the impact of the fibroid lessen over time. And so we're really excited about this procedure that's going to be coming soon to our patients and to all women here. So that finishes up our presentation for the information session, and we really want to hear from you to see if anybody has questions.
And we do have kind of a set of kind of pre-thought questions that we're gonna go over here in a minute. But you know, just to kind of give you guys time to organically think of some questions that you might have, we wanted to give that time here now. So I see there is one question here. Thanks, Danelle. So myomectomy, does myomectomy increase the risk for uterine rupture during pregnancy? So I think that kind of the best answer is yes, it does. Basically what happens is that the uterus is somewhat weakened when we open the muscle and then extract a fibroid and then repair the muscle. And so it's something that has to be kind of thoughtfully considered. And it's not, again, a one size fits all kind of recommendation. It does depend on the size. It depends on the location of the fibroid and how much invasion has to be done into the muscle layers in order to extract the fibroid. So sometimes, and I would say a lot of the time, we do recommend that a woman have a C-section prior to going into hard labor to preempt the risk of the uterus, that uterine muscle failing and causing a uterine rupture at the site of where that myomectomy was done. And so we want to be aware of the risks. It doesn't at all mean that you can't have a pregnancy or that you can't have a delivery. It's just that it's the chances are better, particularly in large fibroids that are through multiple layers, that it would be recommended that you have a C-section for delivery.
I think one important thing is that the hysteroscopic approach, which is where you put the camera into the uterus to remove the submucosal type of fibroids, that is also a type of myomectomy.
Right.
but with a hysteroscopic, so camera in the uterus. So if for some reason your fibroids are treatable that way, then your pregnancy and your method of delivery would be unaffected. So that's also something to know.
And I wanted to just circle back to one other thought too that I had about hysterectomy, because I think, a lot of people hear that term, and I think you described it really well, Dr. Zhang, but, it's important to understand kind of what we're talking about with that too. And, when we're talking about a hysterectomy, many people might immediately think I'm going to be in instant menopause, I'm going to lose all my hormones, and so we want to be thoughtful about that as well, and understand that many times for women, it makes sense to leave your ovaries behind just to remove the uterus or the muscular, part of the anatomy, and still be able to maintain normal estrogen function, meaning that, things like, normal maintenance of your hormone levels with, skin integrity, hair growth, sexual function, maintaining your body temperature regulation, sleep, homeostasis, all these things are left intact despite having a hysterectomy. And so, I just wanted to kind of just throw that in there because it's an important point when someone's thinking about their options.
And I do have a lot of patients come to me thinking that hysterectomy means the ovaries too, and that your hormones will be changed. And so it's important to know that hysterectomy means just the uterus, the muscle part, plus or minus the cervix, but it really doesn't impact the hormones. So yeah, exactly.
Dr. Palmer, are you able to see these questions that are coming in? Okay, so got those 3 questions and then a number of other ones. So do you just want to read them off and then you and Dr. Zhang can respond?
So I'll do this next one. The Exessa from Kristen, thank you. Is Exessa a newly approved procedure or is it just new to Oakdale? Would the fibroids still grow? So the Exessa has been FDA approved since 2012, but it does involve some of that special equipment, the laparoscopic ultrasound and the Exessa device. So the only reason why I mentioned that it's up and coming and new and exciting is that Maple Grove Hospital, and really the hospitals in the Twin Cities, haven't procured the technology. But in our training, fellowship training, Dr. Palmer and I have done the Exessa procedure before in other hospitals. And I believe right now Mayo down in Rochester is the other option for Exessa. And would the fibroids still grow after the Exessa? Potentially, depends on when we're using the Exessa and sort of how their track record is. Have they been growing fast or been relatively stable? Oftentimes they can shrink just enough where it doesn't bother anymore and remain stable in that way.
With patients who have had a myomectomy and their fibroids are returning, what do you suggest as next steps? I think this is the most important thing is, and I always talk to patients about what are your goals? What are your goals with achieving treatment for this problem that you're dealing with? Are we talking about, preserving the uterus for having another pregnancy? Sometimes we will do, and many times often, we will do repeat myomectomies on a patient because, and it depending on the characteristics of the fibroids and on the patient's type, they may have the potential to continue to grow and new fibroids and add more size to the fibroids that they have. And so we could consider a repeat myomectomy sometimes when a person is through their childbearing time frame of their life and they have recurrent fibroids and they think, I just for sure want to be done with this problem. That might be a time to suggest a hysterectomy. But again, the variety of options remain. That all of the things that we talked about are on the table for recurrent fibroids as well. So it's just a matter of kind of your goals and what you're hoping to achieve with that therapy.
So the next question from Christina, thank you, Christina, is if fibroids are removed, is it a guarantee that periods would not be as heavy or pain and cramps with periods would be diminished? So that's a really good question because if you choose to remove fibroids, you want to know that you're going to have the effect that you hope for. And it kind of depends on the size of the fibroid and where it is. If you see your doctor and the ultrasound shows a small fibroid sort of in the muscle of the uterus and not pushing on that inner lining of the uterus, taking that fibroid out may not change your period. It might help with the cramps because the uterus is a muscle, and so anytime there's something that disrupts the muscle, like a little, tumor, big or small, sometimes the cramping can be lessened, and sometimes bleeding as well. But versus if you have a fibroid that's really pushing up on the lining or big and traverses the whole thickness of the uterus, then removing that fibroid certainly is going to improve your periods and the cramping with it.
And I think that that's why it's important to have a proper workup and a proper understanding of what are the specifics of what this type of fibroid you have causing for you, because then we can better understand if we're going to do a certain therapy, what to expect in the outcome. And then Kristen asked, what circumstance would dictate whether a cervix is removed during hysterectomy? So, that's a decision that we would kind of discuss depending on certain situations clinically. We would recommend removing your cervix. Many times the outcomes, the long-term outcomes for removing the cervix or not are very similar. So we talk about pros and cons. For someone, maybe as an example, someone that has a history of abnormal pap smears where there's potential risk of long-term risk of cervical cancer, we would recommend removing your cervix. Sometimes leaving the cervix behind can lead to a risk of future bleeding from the cervix. And so, oftentimes we'll talk about that and we'll recommend removing the cervix for that reason. So there's never I think a hard and fast have to in this kind of scenario. It's a discussion that you have with your doctor, and then we decide what makes sense for you based on your situation.
And then the other thing about the cervix is, medical knowledge has changed and improved over the time with research. So in the past, it used to be counseled that patients that had their cervix removed may experience less pleasurable sex or intimacy, as well as have increased risk of prolapse. And through research over large numbers of women who've had hysterectomy with both their cervix left in place and cervix removed, have found that it has not been shown to statistically increase your chance of having prolapse or sexual discomfort. So that is another thing that we hear a lot about, if that's going to change after hysterectomy with the cervix removed.
Right.
Okay, so from Lynn, we have, I had an endometrial ablation at 50 due to long, heavy periods and did have a couple fibroids taken out during this procedure. It seemed the menopause started soon after with hot flashes. Did the procedure prompt menopause? So the average age of menopause in this country is about 51, which means some women will go into menopause before, in their mid to late 40s, and some don't go into menopause till after. So traditionally speaking, the ablation should lessen bleeding, but not necessarily interfere with hormones or hot flashes, and same with fibroids. It could be that, menopause and the hormones produced by the ovaries were beginning to diminish around that time.
All right, I've got a question here. I have a subserosal 1.5 centimeter and a transmural, which is 3.5 centimeters, distorting the endometrial cavity. What would be the best surgery approach? Is Da Vinci needed?
Yeah.
Well, go ahead, Jane.
So for the 1.5 centimeter one, the subserosal, that's likely not affecting periods, and it is, quite small. The 3.5 that distorts the cavity. So another imaging method that Dr. Palmer discussed was doing the saline ultrasound. Actually, I don't recall if we mentioned that,
Yeah,
but
we mentioned that. Yeah.
A saline ultrasound is just like in the office, regular ultrasound, but we put a little bit of water into the uterus to kind of create this sort of picture or distension to kind of see how much into the cavity, how much does that 3.5 centimeter fibroid stick into the uterus? Because if a lot of it sticks into the uterus, then you might just need the hysteroscopic approach to shave it all down. Versus only if a little bit sticks into the uterus, but most of it's still in the wall of the uterus, then you may need the Da Vinci assisted robotic. And we can pair these two methods together. You can shave some or most of it from inside, like the Pac-Man style, and just shave it down flush, and then go get the rest with the Da Vinci assisted robot.
But I would say, just as kind of a general thought, you know, that 3.5 centimeters is pretty close to the upper limit of where we would think about wanting to do a hysteroscopic approach. When you're getting over 3 centimeters, you know, you think about kind of the length of time that it would take to get to that fibroid, and maybe the, you know, the ability of a small kind of tool like a MyoSure to be able to get all that fibroid. And most likely, you know, we would think about a Da Vinci approach for a larger fibroid that you know, that you can come at from the uterine side and then remove, you know, that way, and then it'll pull that away from this, you know, the transmural or submucosal portion as well.
Somebody else is asking, how big is too big for a fibroid, and when should I seek treatment?
You know, so I think the general theme here that we've been kind of hitting on is really, how is the fibroid affecting you symptom wise, you know? And so yeah, we've mentioned a number of things. It's not just heavy menstrual bleeding. That could be what someone's experiencing, but it certainly could be pressure or bulk symptoms, you know, or it could be bladder or bowel symptoms, you know, abdominal distension or pain with intercourse, or just pain in general. And so, you know, really, how big is too big is whenever a fibroid that you have is causing you negative symptoms that are affecting your quality of life and your health. That's when you should think about treatment.
And so sometimes these fibroids that don't cause the classic heavy periods, painful periods, you know, may be causing symptoms like that long-standing constipation or that ache in your side or your back, that, you know, actually is a symptom, but you just haven't known about it. The other thing is, sometimes big fibroids really can be a good size, but don't cause any symptoms at all. And so, you know, once you've had a thorough workup and, you know, you're comfortable with not having symptoms, you don't have to do anything about it either.
Right.
And I think part of the purpose of this whole event is knowing your options. And you had talked a little bit about the watchful waiting. And so, you know, I think having an action plan, though, with a provider knowledgeable in this area seems to make a lot of sense, right? And so if the action plan is a more conservative approach and then just wait and see what happens with it. So.
Yeah, and these can be monitored over time too. You know, we also talked about, you know, using the imaging modalities like ultrasound, which will allow us to, you know, to understand if we can, you know, maybe like in a year or 6 months, we would rescan and we would see if it's grown or if it's changed in its position, or if, you know, and then decide maybe later it would be a time to act on it, depending on what the fibroid's doing over time.
Because sometimes you want to monitor. I mean, you know, Dr. Palmer and I are pretty good at taking out big size fibroids, you know, grapefruit type size fibroids. But, you know, if you got a basketball in there, sometimes it's, you know, hard even with the best surgical skills. So sometimes if it's not causing problems, we'll just monitor. And as long as it's not growing from an orange and a grapefruit to a basketball, then it's fine to kind of time it. You know, right now is not the best time in your life, you know, just change jobs, or, you know, not wanting to get pregnant anytime soon. So, you know, timing is also important to discuss individually.
Yep.
There's one more, we've got another question here.
In general, how long should I wait before getting pregnant if taking out the fibroid through Da Vinci? That's a great question. I don't think we've addressed that yet. And it kind of depends on everyone's different fibroids. Although generally speaking, if it's a moderate or good sized fibroid, I recommend waiting about 3 to 6 months after for the Da Vinci method, meaning, you know, went through the abdomen with laparoscopy. I generally recommend 3 to 6 months before getting pregnant, you know, and it kind of depends on the situation, whether I say 3 versus 6. What about you, Dr. Palmer?
Yeah, I would agree. You know, it depends on the depth, how much into the muscle and into the uterine cavity you may have to go to extract the fibroid. So generally, if you go through and through, you know, from all the way from the serosa through the muscle and into the uterine cavity, I tend to lean more towards like the 6-month side of things, versus if we're just kind of taking it out of the superficial layers and we're not going deep all the way through into the cavity, we would, err more on the shorter side, like 3 to 4 months.
And the reason is because once a fibroid's removed, you have this space and we close it up in layers. But the uterus is a big muscle and it has to take time to heal those layers. Pregnancy, can grow very quickly, expanding with the baby and fluid, and that can provide a lot of undue stretch on this uterine scar if you get pregnant too quickly. And as someone said earlier, does this increase the risk of uterine rupture? Uterine rupture is the term for the uterus kind of splitting open along, whether it's a prior C-section scar or people who've had large fibroids. So to try to minimize that risk, it's never zero, but we always try to minimize the risk. That's why we recommend waiting certain amounts of time.
Mm-hmm. All right, I got a question from Courtney. If we already have a primary provider at Oakdale and are interested in further investigation, can they complete the testing imaging, or do you recommend we schedule an appointment with one of you? I would say that maybe that depends. Probably the best answer is that if you have fibroids and you're considering doing something about it, it's better to probably just see one of us so that we can design the best diagnostic approach as well as the treatment approach, because it may not, you may go through an ultrasound or something that we wouldn't do necessarily, and then you've gone through something that you didn't need to. So but it's always best if you have a physician or a provider that you trust, that you have seen for a while, and you have an established relationship with them, and maybe they've been following this fibroid for some time for you or something, and they can certainly order the proper testing to get us the information. But it's, so I don't know if I really answered that question. I think it depends on the relationship that you have with your your primary person. And then, deciding if you're going to do something about it, and maybe you need an MRI or something. I'll often have, one of my partners will order that. And then they'll send them to me for the myomectomy, and they've already then kind of got the ball rolling, so to speak, so that we already have an MRI and we already kind of have gone through that step even before the consult. And then I can take that information at that initial meeting and just go over it with the patient right then and there. So that might make a lot of sense, in that case. So I hope that helps. I mean, it's kind of an open-ended answer, but.
And when in doubt, just ask. At Oakdale, we have
exactly.
a really good line of communication. We cross-talk to each other all the time.
Yeah.
Between the nurse practitioners, the midwives, the doctors, we're always talking and sharing information. So, just, feel free to ask your primary care at Oakdale to ask one of us what you think you should do before meeting us, and we can kind of set things straight for sure.
Yep. Ivy, you can ask her second question there.
When considering IVF procedure, should fibroids be removed out first? How much does medications, hormones stimulate fibroids? Yeah, so that first question is important. And I would say that, if you're considering IVF, you're likely, in close contact and under the care of a reproductive and fertility specialist. And so I would pose that question to the person who's doing the IVF, because it may be a fibroid that, they don't think really will impact things, and then, doesn't have to be removed. And we can also kind of offer opinions and then have you see them as well. Because, sometimes fibroids, if they don't have to be removed, then you could then go on to have a vaginal delivery versus, recommending for a C-section. But
right. Then how much? Yeah, go ahead.
Go ahead.
Okay. Yeah, I mean, it definitely, the medications that are used to, to stimulate egg production and go through the process of IVF can definitely stimulate fibroid growth. So it's something that, you take into the consideration for when the timing of treatment is important. I would say, again, it really depends on the location and the size, but, when people are trying to optimize their chances of having a successful IVF procedure, obviously they're going through a considerable amount of treatment and cost. We really want to, generally consider having the optimal situation from an anatomy standpoint for that procedure. So oftentimes I would say that most REIs would want a fibroid removed before they put a patient through the IVF therapy.
Yeah, I would agree. Most REIs want, having the most optimized anatomy that you can, including fibroids and polyps and abnormal tubes and that sort of thing. Yep.
Yeah. Those were awesome questions. We have a few more that we just thought of between the two of us that we can throw up on the screen now, and hopefully this will, also jog some additional questions if they come up. So feel free to continue to chime in with questions. Maybe we'll just go back and some of these we probably have already addressed, throughout the talk. So I think the first one we probably addressed pretty well already. You don't need to necessarily treat asymptomatic fibroids because, like I said, a lot of times these can be found by incidental finding where there's a scan or something being done for another reason and they're discovered. So I think that answers that question. You want to take number 2?
Yeah. So what's the best procedure to consider when fertility is a concern for a patient? The medications to decrease bleeding, they can be started and stopped and don't impact future fertility, although you shouldn't be actively trying to get pregnant when on those medications. The procedures, the uterine artery embolization is actually not indicated for women who wish to continue to try to get pregnant in the future. So if that's something that you want to keep that door open, the uterine artery radiology procedure is really not a good option. Certainly not hysterectomy, but myomectomy generally is when you want to hopefully get pregnant in the future. The data for Exessa, which is that ablation, that heat controlled ablation on the fibroid, right now they're still looking at sort of case reports, and the case reports for pregnancy after that procedure show good outcomes. So if you happen to get pregnant after that procedure, most likely outcome is good. However, it's not currently in the category for women who for sure want to get pregnant in the future. But there's, like I said, with medical information, that we're always getting new information, so there's more to come on that.
Danelle asked a question here. Is there an association between endometriosis and fibroids? So this we didn't really address endometriosis at all in this talk, but yes, endometriosis and fibroids can be related in that they're both estrogen dependent types of problems that can occur in women. And so oftentimes people that are being treated for one or the other problem, either for endo, we might find fibroids incidentally, or if we're doing a myomectomy or something, we might see endometriosis. So really the association is the estrogen dependency of those tissues and how they respond to estrogen in certain people's bodies, and so there's a common thread in that they do often go hand in hand with people. All right, so will fibroids reoccur again after they are removed? So, there's a variety of ways to understand this. And I think the data would suggest that the biggest factor is the number of fibroids and the location of the fibroids. So people that, there's kind of different presentations of people that have fibroids. Sometimes people have many fibroids. They have fibroids of all different types of sizes and shapes. And, they can have, like that image that was at the beginning where it kind of showed the different locations, subserosal, submucosal, intramural. I see a lot of people that have all of those in one uterus. Okay. And so, I think the biggest understanding is, when you look at the data, the lower recurrence rate generally occurs in people that have a single or maybe a couple fibroids that are completely removed, and they're not having this kind of multi-fibroid uterus presentation. People that do have lots of fibroids, we generally approach it from the aspect of something like a myomectomy is to do as thorough of a debulking of those fibroids as possible. So, my goal is to use the imaging like the MRI, and then obviously what I'm seeing live in surgery to try to get every fibroid that I can, knowing that many times in women, they've got fibroids that you can't see, even with advanced imaging like MRI. They may have a fibroid that's the size of a grain of rice or a pea or something, and that over years is going to grow, and so, really the best answer to that question is that it depends. And, we want to look at the number, the location, and the size of the fibroids to get the best kind of idea if you have a higher chance or not of recurrence.
Yep. Okay. So next question, we had kind of addressed a lot already. Why recommend a hysterectomy for some patients and a myomectomy or other procedures for others? Do fibroids go away in menopause? They don't really go away. Sometimes with the drop in estrogen, they may shrink, and they may shrink a little or shrink a lot. However, they don't ever truly go away. So some women, despite not having periods, may be discovered to have fibroids that are big enough to cause some of those pressure or bulk symptoms.
All right. Can these surgeries be done minimally invasively? And so I think, I really liked what Dr. Zhang said, in that kind of the way that the two of us, and, those of us that do a lot of fibroid surgeries at Oakdale, we tend to approach the surgery with kind of a default setting that we're going to try to do it minimally invasively if we absolutely can. It's a big priority of mine with the training that I have and the experience that I have to try to be able to offer that to a patient, just because we've been able to see the dramatic difference in patient outcomes in how quickly people are returning back to their normal activities, minimizing any time in the hospital, minimizing risk of blood loss, on and on about why minimally invasive is better. And so we really try to be thoughtful about that. And I would say it's pretty rare, honestly, that we can't do a procedure for a fibroid, whether it be hysterectomy or myomectomy or Exessa or hysteroscopy, minimally invasively. Generally, we can, and that's a big priority for both Dr. Zhang and I to look at things that way.
Definitely, yep. Alrighty, so what are implications for vaginal delivery versus cesarean delivery after myomectomy? We kind of addressed that as well, with where the vaginal delivery would be totally possible if the fibroids were removed just through the hysteroscopic approach, or if they were sticking out from the uterus quite a bit, but the actual involvement in the muscle or the wall of the uterus was shallow, or even just like on a branch or a stalk kind of dangling off. Those would be totally fine for vaginal delivery. However, if it really disrupts the muscle, the thickness of the uterus a lot, then it's really safer to have a cesarean delivery as the method of having your baby after a myomectomy.
The last one that we have down, I think I also addressed this earlier, but how do medications like the GnRH antagonist work? Basically, just to recap on that, it reduces your estrogen levels. And so what we know happens is that when you take away some of the estrogen support that's kind of fueling the activity of the fibroids, they tend to have less activity. And so really how that translates as far as symptoms is it dramatically reduces bleeding in people that are suffering from heavy bleeding related to fibroids. So we are really near the end of our time here. And you guys, thank you for sticking around, those of you that did. And, as Kristen said, this is recorded and it's going to be available to anyone and all that want to access this information again from our website. Is there any other final questions anybody has before we jump off here?
All righty, great.
Right.
Well,
Thank
hope you all
you.
enjoyed, yes, the talk.
Thanks so much. We appreciate your time. Bye-bye.
I see one here.
Oh, there's one.
Thank you so much. All right, Ivy, you're welcome. Thanks for joining us.